Damn those Romans and the 28-day February. It would be so much easier if this month had 30 days and they took a couple off the 31-day months. But on the other hand, you get to have me that much sooner for another Puscast. This one covering February 15th through 28th, 2013. Remember that the world does need more Mark Crislip, and you can find more of the same by going to Amazon and searching for science-based medicine, where you will find eventually 12 volumes of the collected essays of the bloggers of science-based medicine, covering everything from acupuncture to quackademic medicine. Only $4.99. It's published in conjunction with the James Randi Educational Foundation and is available for the Kindle, the Nook, and the iPad. Get your copies today. They make wonderful gifts for you and your loved ones. But now you're here for the infectious disease literature, are you not? Let's get to it. I'm going to start with some molecular microbiologic archaeology, which is cool. This was in the journal Science, but reporting on an article in Molecular Biology and Evolution, where they looked at studies that evaluated the effects of molecular techniques on the origin and spread of Streptococcus mutans in human beings. In my world, mutans is a cause of endocarditis, but it looks like it's new to the human population. They went back to old teeth and they could not find evidence of strep mutans in it until we got to an agricultural society. And they estimate by molecular techniques that strep mutans started to spread across the human population about 10,000 years ago when agriculture became common. The organism loves to cause cavities and does so as it eats and ferments sugars. They also found strep mutans predominantly in ancient farmers, but not in ancient being about 10,000 years ago, hunter-gatherers. Yet another reason why ID is so much more cool than any other specialty in medicine. At least as I write this, the new coronavirus is still a problem, and no, you don't get it from lousy beer. This coronavirus has been found predominantly in Saudi Arabia, Jordan, and 2 cases in Europe. There have been 13 cases total with 7 deaths. So far, it looks like it probably is coming from bats and or goats, and whether this is a common illness that occasionally kills or a rare infection that always kills is as of yet undetermined. You may remember back to the SARS virus, which was also a coronavirus that probably came from Chinese bats. Hopefully when these things jump from animals to people, not that people aren't animals, that it doesn't become both virulent and infectious in our population. That would be a problem. I remember the bad old days of HIV. I was in medical school when the first cases of AIDS started, and I've been around for the worst of it. And things are so much better now since no one dies of the disease secondary to heart, or at least a lot fewer die. There's still tobacco, and smoking is a bad thing if you are an AIDS patient or an HIV patient. The reason is that it kills you at higher rates than it does if you're a non-smoker. The excess mortality is tripled in HIV patients, and the attributable risk of death is double in HIV patients as well. HIV patients get earlier lung cancer and more widespread lung cancer, amongst other things, and given the cardiovascular complications of heart, somewhat ironically named, the last thing you want to do is add the synergistic cardiovascular disease that smoking provides. So, if your patients smoke and they have HIV, the data would suggest a compelling reason to stop smoking. It's not the HIV that's going to kill them, it's going to be the tobacco. France had a measles outbreak in the end of the last decade. Between 2008 and 2011, they had over 22,000 cases of measles, the vast majority of whom were in unvaccinated people. This led to 5,000 hospitalizations, 1,000 who had severe pneumonia, 27 who had encephalitis, and 10 people died of measles. In fact, they had predicted an outbreak in France because vaccine rates had been falling in some areas, with parts of the southern France being less than 85%. So you can weigh the risks and benefits. Risk of measles vaccine causing autism? 0. Risk of morbidity from measles when herd immunity falls? Quite substantial. Seems a simple trade-off to me. Unfortunately, we have lost track of the morbidity and mortality that the childhood illnesses can cause if we don't protect ourselves appropriately. The diseases are always worse than even the real, much less imagined, complications of the vaccine. I have never seen a case of measles, and I hope that I never will. I've also never seen a case of smallpox, but in 2012, someone got vaccinated against smallpox. He then had sex with someone, and that person, who had had a prior history of eczema and psoriasis, developed smallpox. That person, in turn, had sex with someone who had a history of eczema, and that person as well developed smallpox. So the take-home, I think, is do not have sex with smallpox people. Actually, the take-home is the interesting epidemiology of how the disease was transmitted from the primary to the secondary to the tertiary in people at risk for developing disease from the vaccine smallpox, i.e. those with underlying skin disease. One patient predominantly had the pox on his penis, and all I can say is, ew. There was a brouhaha, at least in our local paper, about the efficacy of the current flu vaccine being no good in the elderly. And as usual, there are fine points to the efficacy. The CDC released information looking at how good the current flu vaccine is. They estimate that it is about 47% for influenza A, the H3N2, and 67% against the B, which isn't bad. However, when you look at the elderly, the rate of efficacy against influenza A was only 9% for H3N2, which is not hog heaven. However, in the elderly group, it was still effective against B, with a protection rate of about 67% for the B. So across the board, about half to two-thirds of people will be protected from the current vaccine, with the exception of the elderly, where they don't get a response to the H3N2. So what would be the best way to protect the elderly? Perhaps if the young people who are able to mount a response with the vaccine don't get the flu, they won't pass it on. What a clever idea. Maybe we should call it, what do you know, herd immunity. I think I will trademark that. And since it's an interim estimate of efficacy, there may be some data sampling that will be shown later to unexpectedly give the rates lower than they actually are. In contrast, the H1N1 vaccine program is estimated, at least by an article in Emerging Infectious Diseases, to have prevented somewhere between 700,000 and 1.5 million cases of flu, between 4,000 and 10,000 hospitalizations, and between 200 and 500 deaths, which isn't bad. Efficacy of the flu vaccine varies year to year, strain to strain, host to host, and I still look at the flu vaccine as like seatbelts and airbags. I would rather be in a car crash with them than without them. Similarly, I would rather be exposed to flu having been vaccinated than not. I've actually never had influenza, and I get my vaccine every year. Interestingly, the only time I ever get colds, rhinoviral infections, is when I take echinacea and vitamin C. Go figure. If there were a race to become the first totally resistant pathogen, it would be a toss-up as to who's going to win, Staph aureus or gonorrhea. Right now, I think gonorrhea is in the lead. Resistant gonorrhea is taking off across the world, and it's been really going hog heaven, as it were, in England. So for those of you who are going to England for vacation, Just remember that it is up 25%. Because of increasing quinolone resistance, there are now new guidelines for the treatment of gonorrhea. They should get an IM injection of 250 of ceftriaxone plus either a gram of azithromycin as a single dose or 7 days of doxy. If there's no ceftriaxone around, it's 400 milligrams of cefixime with either a single dose of azithromycin, 1 gram, or doxycycline for 7 days. And if they're allergic to cephalosporins, they can be given a dose of azithromycin, 2 grams. And everybody should get test of cure. For years and years, the infectious disease literature was predominated by studies out of U.S. and England and France. Now there seems to be increasing articles out of China. And with economic progress comes syphilis and other STDs. And there was an article out about neurosyphilis presenting only as epileptic seizures. Over a 6.5-year period, they looked at 169 patients with neurosyphilis and found that epileptic seizures was the only presentation of about 7.7%. They suggest that seizures can be the only manifestation of neurosyphilis and that people presenting with seizures should, as part of their workup, be evaluated for the presence of syphilis. Seems reasonable to me. The spread of plague has always been classically said to be due to fleas. However, can it be spread by the body louse? The answer would be yes. They took 154 body lice and 35 head lice in the Republic of Congo, and they could find plague bacillus in 3 of the specimens and Bartonella quintana in about a third of the specimens, and suggests that plague can be spread by the body louse as well as by fleas. I'm back. You probably didn't notice I was gone. But I went out for a nice dinner and then went and saw the Alabama Shakes with my wife, and they started at 11 o'clock at night. Ugh, I'm too old for this stuff. So after standing for 4 hours late at night, I'm creaky and groggy, which I believe is a law firm. But let's move on with the Puscast. I've always felt sorry for dogs. They have to smell each other's butts. This dog was trained to identify C. difficile. I just find this amusing. There was that African rat of some sort that was used to identify tuberculosis with high sensitivity and specificity. They trained a beagle to smell C. difficile. And I know the nurses are always saying that the stool smells bad. It smells like C. difficile. All stool smells awful to me. Maybe our nurses are better than I thought at identifying C. diff. But they trained this dog to sniff for C. diff. Kind of rhymes. And so they took this dog on rounds and they tested it to identify C. diff. And it correctly identified 25 of 30 cases with about an 83% sensitivity and 265 of 270 controls for a specificity of 98%. Poor dog, though. Man. I'm always amazed at the ubiquity of pathogens in the environment. Salmonella can come from all sorts of odd places. I've mentioned salmonella that has been picked up from kids' sandboxes and from pet food. There's now a reported outbreak of Salmonella typhimurium associated with pet hedgehogs, or maybe hedgehogs, probably named Eric, that has infected multiple people across many states in 2011 through 2012. It brings to mind the importance of cooking your hedgehogs to 165 degrees to make sure that you've killed off any salmonella. Oh wait, these were pets. I'm sorry. I rarely quibble with initial antibiotic coverage when it's a wee bit on the excessive side, because if you guess wrong, your patients are more likely to die. Inappropriate initial therapy increases death rates, and this was true in a study out of Spain that looked at outcomes in MRSA bacteremias and found that if you had the wrong initial antibiotic, you're more likely to die up front. Because of the ubiquity of MRSA, virtually everybody gets started on vancomycin these days for a wide variety of infections. But when can you stop the vancomycin? This study looked at discontinuation of empiric vancomycin in patients with MRSA, healthcare-associated pneumonia, and found that you could do it safely if, and this is in the absence of lower respiratory tract culture, so you don't have a good sputum for culture, if the patient did not carry MRSA in the nose and throat, and they had a clinical pulmonary infection score of less than or equal to 6, i.e. they weren't very sick. So just because you start an antibiotic doesn't mean you can't stop it. Many people think that once you begin an antibiotic and the patient responds to said antibiotic, that the only time you can stop the antibiotic is when the sun goes nova. But actually you can use both clinical parameters and cultures, as in this case, to discontinue antibiotics that are not needed. I have one physician who likes to consult me for the very purpose of stopping antibiotics. A while back, I mentioned an article in Medicine that demonstrated that if you had a gram-positive bacteremia, about half of patients had a focus somewhere, endocarditis or abscess, and of those, only half were clinically symptomatic. This is again confirmed in an article in European Journal of Clinical Microbiology and Infectious Diseases that looked at Staph aureus bacteremia and the role of TEE in diagnosing unsuspected endocarditis. So they had 144 people with staph bacteremia, and they all got TEEs. Endocarditis was only clinically suspected in 15% of the cases, but of the 144 patients, 37 had a veg on TEE, of which 19 were not suspected clinically. So in this study, about 13% of your patients with staph bacteremia will have an unsuspected vegetation on echo. That's a lot. I used to think that the recommendations for everybody with staph bacteremia getting echoes was a wee bit excessive. I think the data of late confirms that I was wrong. And finally, if there's anything that people screw up the most on in my world is the treatment of Staph aureus bacteremia. Patients should get a minimum of 14 days of IV therapy, and this was confirmed in an article out of Korea where they looked at outcomes in patients who got shorter or longer courses of therapy for staph bacteremia, and found that patients who had less than 14 days had about an 8% chance of relapse. That being said, the group that had the highest chance of having a relapse were those with a primary staph bacteremia, i.e. staph bacteremia without a reason. That is always endocarditis, and I can't imagine not treating those patients for at least 4 to 6 weeks, even if they had a negative echocardiogram. But nobody listening to this podcast would even think of managing Staph aureus bacteremia without an ID consult, since multiple studies have shown decreased morbidity and mortality. You really do need to know your local microbiology. There was an article in CID that pointed out that a third of community-onset ESBL-producing E. coli's were in patients who had no healthcare-associated risk factors. So ESBL is spreading through the community, not a surprise that when it's in an E. coli, and I'm sure the metallo-beta-lactamase is not far behind. If it's a problem in the United States, that's nothing compared to China, where evidently 60% of their E. coli are due to ESBLs. They looked in this study at how long you carry an ESBL-producing E. coli by looking at medical students, who evidently are not washing their hands, and found that ESBL-producing E. coli stayed in the stool for a mean duration of time of 59 days, with a range of 14 to 112. Now, these are healthy medical students. I don't know if that could be extrapolated to a more immunocompetent population, One of the many nice things about the Great Pacific Northwest, specifically Portland, is we're always a little behind in terms of antibiotic resistance. But you really need to know your local antibiotic patterns before you can rationally give empiric therapy to patients with serious infections. And another study out looking at time to positivity shows again the sooner you get positive cultures, the worse are you going to do. This looked at gram-negative bacteremias and found that time to positivity predicted mortality. Get this, for every hour that TTP, time to positivity, not thrombocytopenic purpura, was shorter, mortality went up by 10%. That's pretty remarkable. Also, not unsurprisingly, you had high mortality in patients who had inadequate empiric therapy and patients who had ESBL producing gram-negative rods. I'm sure the time to positivity is just a marker for how much bacteria you have in the bloodstream, and that's always a bad thing. They're having fun in England. Besides an increase in gonorrhea, there is a reported increase in pneumocystis, and the epidemiology is interesting. One group that had an increase was those with underlying lung disease. This was a hodgepodge of things, including ILD, bronchiectasis, asthma, CF, and COPD. And there's some interesting literature about pneumocystis perhaps exacerbating COPD. More interesting, to my mind, was the percentage of patients who had underlying connective tissue disease who had pneumocystis. In 2005, it accounted for 7.6%, but from 6 to 2010, it accounted for 9.1%. There is a habit of patients being put on steroids with either COPD or collagen vascular disease to be put on pneumocystis prophylaxis. When you look in that literature, it is impressive for the lack of data to suggest that pneumocystis prophylaxis is of benefit. This study, which is epidemiologic, would suggest that pneumocystis is more common in these populations than one would otherwise suspect, with collagen vascular disease accounting for 9% and underlying lung disease accounting for 21% of cases admitted with pneumocystis between 2006 and 2010, and the increased use of all sorts of immunosuppressive agents. Perhaps pneumocystis prophylaxis is not as irrational, or at least not indicated, as I had hitherto thought. Hitherto. There's a word I don't use often enough. Of course, what we really need are studies to show that giving patients with COPD or lupus on steroids, Bactrim prophylaxis, causes more benefit than it causes risk, because certainly Bactrim is not the most benign of therapies. They don't think that the increase in pneumocystis was due to either increase in testing or increased detection by using the PCR instead of the old stains. I recently had a case of miliary tuberculosis with septic shock, and as is often the case, there's now an article out on Mycobacterium tuberculosis septic shock. And not unsurprisingly, patients do poorly. It had an in-house mortality rate of 80%, especially if the patients did not get started on prompt antibiotic therapy directed against MTB. Our patient had a several-day delay until we got an AFB smear, which led us to suspect miliary tuberculosis. There is, BTW, a nice review in Current Concepts in the February 21st New England Journal on tuberculosis. As is often the case, the bugs are more variable than we suspect. This is true of the fungi, and specifically in a recent article, blastomycoses. There are two different types of blastomycoses, and they cause two different infections. One, type 1, tends to cause predominantly a pulmonary symptoms, and group 2 more likely cause disseminated disease in older patients. So, not unsurprisingly, different subgroups of blastomyces will cause different diseases in human beings. I think one of the bankrupt issues in infection control is we rely upon our patients to ask us if we've done hand hygiene, which is always appalling. I mean, seriously, we've known about hand hygiene for 160 years. We can't wash our damn hands. Would you go on an airplane where the motto was it's okay to ask if there's fuel in the tank? I don't think so. And a recent study published demonstrated that patients, while they think their healthcare providers should wash their hands, are by and large hesitant to remind their healthcare providers, as they should be. Failure to do such a core competency of infection control is appalling, and really, relying upon the patient to remind us to do our job adequately is one of the many morally bankrupt aspects of infection control. The other is, by the way, that we have secret shoppers who watch us do hand hygiene, fail hand hygiene, and then don't intervene to make sure that the hands are foamed. The fact that we watch people fail and do nothing about it, not in my institutions, by the way, is really one of the more appalling aspects of infection control. If you saw someone fail to give antibiotics, you'd remind them in the perioperative period. But for some reason, we watch people spread contagion and do nothing about it. Again, not at my hospitals. And I think we'll end here. This ends another Puscast, a review of the infectious disease literature for the last 2 weeks of February 2013. Don't forget to go to edgydoc.com to find links to the books and the podcasts and the apps and lions and tigers and bears. Oh my. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you, although it will be difficult to tell since Epic fails to give a good narrative of the patient course. Thank you. In dictation. Goodbye.